Assalamu alaikum. I'm Dr. Sajid, and I am very thankful to the Pakistan Society, Pakistan Society of Neurology, and especially Professor Mohammad Wase for giving this opportunity to present about COVID and ICH. So I have no disclosures. So COVID-19 pandemic, it has affected all the countries, and almost every one of us is affected by COVID. So these are the current numbers I just updated last 2 days back. So total cases worldwide are about 245 million, and total deaths are more than 5 million now. And in Pakistan, we have around 1 million confirmed cases with around 28,400 something deaths. Nowadays, the numbers are a bit reduced, and we hopefully this pandemic will end soon. So neurological manifestations in COVID. Initially, it was thought that COVID is a respiratory illness, but as the time goes on, we noticed many neurological manifestations, and various studies have reported from 13.5 to 36% of patients having neurological manifestations. And these manifestations are very diverse. They involve central nervous system causing a stroke, as Dr. Maria just mentioned. It causes many peripheral nervous system disorders, myopathies, neuropathies. Even we have seen some cases of myasthenia associated with COVID. So these neurological manifestations were highlighted when increased risk of thromboembolic complications were noted, especially in those patients who had severe COVID and were admitted in ICU. And these thrombotic complications included ischemic stroke, large vessel ischemic stroke. And for these purposes, anticoagulation was usually given to COVID patients. Most of them were in the preventive doses, but in some centers, in high-risk patient, full doses were also given. So there was always a risk that with increased anticoagulation use, there will be increased risk of bleeding, including increased intracranial hemorrhages. So far, the data about ischemic stroke in COVID patient is well described and is present, but the data on ICH is very limited and scattered. ICH has been previously reported in the literature in connection with various other infections like enterovirus, herpes virus, even SARS-CoV-1. So we thought they might have some relation with SARS-CoV-2 too. So what is the hypothesis? Why we think that COVID is related to ICH? One of the reasons is that the COVID virus SARS-CoV-2 has a neurotropic potential. It enters the cell through S2 receptors. And this hypothesis is strengthened by the presence of viral particles within the endothelium, the vascular endothelium, even in the cerebrum, cerebrovascular tissue, as viral inclusion particles are present. Second, in CSF, we have detected viral RNA. So it shows that this virus enters the nervous system. Then the virus binds with the S2 receptor. Now this S2 receptor, it cleaves angiotensin 2. Now normally angiotensin 2, it increases the blood pressure. So if it is not degraded, then the local concentration of angiotensin 2 will increase. So what it will cause? It will cause increased blood pressure, which may cause hypertension. Further, it can attach with the angiotensin 2 type 1 receptors, causing lung injury, inflammation, leaky vessels. Now these leaky vessels will again predispose to the hemorrhagic stroke. So we thought this might be the cause. Apart from these S2 receptors, there are pro-inflammatory cytokines and increased oxidative stress, tissue inflammation, which might increase the risk of hemorrhagic stroke. These patients also had coagulopathies, which increase the risk of stroke, hemorrhagic stroke, and anticoagulation therapy. So in one study, which comprised of around 3,824 patients, the patients who were anticoagulated, they had a 5-time increased risk of having ICH. So these were the hypotheses, that these were the reasons that might cause an increased ICH in COVID. But what the real data says? So most of the published literature is about case reports of intracranial hemorrhage with COVID, or very small series. So I searched it, and I only highlighted the studies with higher numbers. So if you could see the first 3 studies, there are a lot of numbers. The total COVID-19 patients are more than 26,000, 21,000, and 14,000. And these are all 3 are multinational studies. So the important thing is that the percentage of intracranial hemorrhage in these patients is small. It's around 1.1 to 0.2% in the first three large studies. Even the highest number of cases reported are 48 in more than 21,000 patients. And the second thing is that almost all of these patients had vascular risk factors. They were hypertensive, they were diabetic, they had ischemic heart disease. So how COVID is causing them, or only this is just an coincidental finding, we are still not sure. But the main important thing to consider is the mortality. If you see the mortality, it's around 40 to up to 60%. So it's a very high mortality. We do not see these kind in our routine ICH patients, which are non-COVID ICH. So I am just discussing few studies. This is a recent study published in Journal of Stroke. Now, this is a multinational study, and more than 21,000 patients who were admitted with active COVID-19 were included, and only 0.2% had ICH, only 48 out of more than 21,000 patients. But the important thing is that the patients who had ICH, they were of increased age, they were of male gender. 75% of them were anticoagulated. It means 3 out of 4 were having anticoagulation at the time of hemorrhagic stroke. They were severe patients, 90% needed ICU support, and 48% mortality. So this is a table of this study. You can notice that most of the patients with ICH were over 65 years. Second, they were severe and needed ICU care in around 90% of the cases, and mechanical ventilation was needed for 77% of the cases. Third, about the treatment, that 75% of these required anticoagulation, but they also required more tocilizumab, more remdesivir as compared to the non-ICH patients. It shows two things. Number one, that these patients had severe COVID. That's why they were given these kind of treatments. Number two, there may be side effect of these treatments, which we are still not sure. And third, mortality. The mortality was very high as compared to the non-ICH COVID patients. Then there was a second paper published in a Neurocritical Care Society, Neurocritical Care Journal. Now they had data of 4,071 COVID patients, and out of which 19 patients had ICH. Now they compared these patients who had ICH in COVID patients with ICH in non-COVID patients to see the difference. So they noticed that the patients who had COVID and ICH, they had higher initial NIHSS scores, 28 mean score versus 13, and it was statistically significant. And they had less deep hemorrhages. So usually we find deep hemorrhages within basal ganglia, thalami. So these hemorrhages were not that common in COVID ICH. Further, they were on anticoagulation. Most of these patients, they had higher PTT levels, higher fibrinogen, and higher mortality. And all of these were statistically significant. Now, this was an interesting study from China. So they noticed the ICH patterns in pre-COVID in 2019 and then 2020. They selected 2 months from January to March, and they wanted to see वाकई कोविड का मसला है या बिकॉज ऑफ द कोविड पेंडेमिक तो स्ट्रोक यूनिट्स बंद किए गए, कोविड सेंटर्स में तब्दील किया गया, स्टाफ शॉर्ट हो गया था, या उसकी वजह से मोर्टेलिटीज चेंज हो रही हैं. सो दे सिलेक्टेड द पेशेंट्स from 2 months in the pre-COVID era in 2019 and then similar 2 months in the 2020 जब वहाँ पे स्टोरेज यूनिट बंद किया गया था एंड कोविड सेंटर में चेंज किया गया था. एंड दीज इंक्लूड ऑल द पेशेंट्स ऑफ ICH irrespective of their COVID status. So they noticed there was no change between pre-COVID and COVID areas. Even the demographics were same, risk factors were same. The only difference they found that even the NIHSS was better that presented in the COVID era as compared to pre-COVID era. So COVID era, because of the shortage of staff, because of shortage of facilities, there was no increased mortality. So there was something else. So this was the their findings in a picture way. In COVID-19 period, there were more patients with a minor stroke, which are mentioned in blue, than pre-COVID, and there were less number of severe ICH in this COVID-19 period. Now, this is some of the data from our center. At AKUH, we are collecting the neurological. We have seen the neurological manifestations with COVID, and it's not published yet. So, at the time of preparing this presentation, I have seen how many hemorrhage patients we have seen. So, we have seen only 10 patients who were admitted with COVID and had ICH, and their mean age was around 57 years, with 90% of male. They were 80% of these were hypertensive, and 30% of them required ventilatory support. and all presented in acute state within 4 weeks of acute infection, acute COVID infection. Interestingly, 90% of them had symptomatic COVID. So they were admitted with symptomatic COVID. They had respiratory issues. They had fever. Because of these respiratory symptoms, they were given steroids, and remdesivir was given in half of the patients, and mortality was 50%. So again, our data also is similar to the previous presented data that mortality in these patients is high. So again, the question comes, is COVID-19 infection is the cause of ICH, or is it a coincidence with ICH? So answer is still we don't know. The incidence is not that high, 0.2% is only, but since the mortality is high, so there is a suspicion, a hypothesis that COVID is causing some detrimentation of the already vascular factors, and more mortality is seen in these patients. So in conclusion, the relationship between COVID-19 and ICH is still not clear. We are not sure. The most of the patients who had ICH and COVID, they usually have moderate to severe COVID infection, and their mortality is high. And the treatment recommendation are same. That control the blood pressure, control the risk factors. If patient is having coagulopathy, correct it. If patient is having anticoagulation, stop it.